You're here. You did it. Welcome to this final installment of this 2021 blog series. I'm Matt Bobman, and I'm happy that you're watching. Our latest guest blogger is Keith Knurr. Keith's a PT out of Wisconsin and currently pursuing a PhD at the University of Wisconsin. He's doing some really cool research looking at how biomechanics change after ACL injury and how these changes can relate to performance. Keith, welcome. Thanks for joining.
Thanks for having me, Matt. It's great to be a part of the blog series.
Yeah. You wrote us a really great post, and we got some good questions. I think we'll have a productive discussion here. But before we get started, would you mind just telling me who you are and tell me more about your lab and what types of things you're studying and what you're learning?
Yeah, absolutely. So, as you said, I'm at UW-Madison. I'm doing a PhD through what's called the Clinical Investigation Program, but all of my research really emphasizes around running biomechanics and neuromuscular performance recovery after ACL injury. And so we have a pretty unique setup at UW-Madison where we're able to look at the collegiate athletes longitudinally throughout the season and before and after injuries and stuff. So it allows for a pretty unique data set, and it allows us to answer some interesting questions. So that's where I'm at currently. Is there anything else you want me to dive into or anything along those lines?
Well, where are you at in your PhD studies? What year are you, or how much longer are you looking at?
In my second year. So I think I saw on one of your posts you said that I'm a PhD candidate. Not quite, almost. I'm still,
what's the distinction? I know there's a little difference there.
It's semantics, but before you do your preliminary exam. So I have to pass that first, which I have scheduled in August. So it's coming up. Hopefully that'll all go smoothly, and then I will be. But yeah, so I'm 2 years in, almost. I started in the fall of 2019, and then hoping to finish up in about 2 more years. So.
Okay. And so what's your technical title right now?
My dissertation is really kind of revolved around running biomechanics following ACL reconstruction. I don't have a really set, I guess, title, but it all is tied into that some way. But yeah.
All right. And then you're in the clinic too, right? You're treating patients?
I am, yeah. I'm in the clinic part-time right now, so I'm probably about 8 hours a week or so, give or take, depending on the week. But yeah, I'm at UW Health. It's where I did my sports residency. So I stayed on there as a PRN PT and primarily seeing an athletic population, which is great. I see a decent amount of post-ops, which is where my interests lie for sure. So it's a really fun clinic to work in. I'm glad to stay in the clinic. I think it's important.
Excellent. All right. So you wrote a really great post, and I told you in an email that clinicians, at least I do, have a really hard time reading biomechanics literature. There's lots of abbreviations. There's lots of concepts that I haven't thought about for a decade. Moments and stuff. So I asked you to put together a little presentation, sort of expanding on your blog posts into different variables we're looking for. So we can share that now, and would love for you to just walk us through it.
Yeah, absolutely.
Okay, so your screen is shared, so you're good to click through when you're ready.
Great, yeah. So before I advance, I guess, to the next stage, I do want to thank everybody from my lab that really helps with this project. It's definitely a team effort to collect the data the way that we do. But here's a few pictures of our lab. On the right, you can kind of see where our treadmill is set up, and then some of the cameras. We have full motion capture system surrounding our instrumented treadmill there. And then we also have we have a Biodex and a DEXA scan and some other force plates and things that we can do to measure various measures of either functional, clinical. We look at neuromuscular performance, so looking at EMG activities as well and things like that. So really pretty rich amount of data that we can get from our lab, and it's a great place to work at. So
what are you looking at with the DEXA scan?
Yeah, that's a side project of mine, actually. Part of it. So we scan all of our athletes at UW-Madison with the DEXA scan at preseason and usually mid and postseason. But particularly with the post-op ACL patients, they are getting scans about at the same time that we do all of our other data collections. So running, jumping, hop testing, quad performance. We get DEXA. And one of the things I'm really interested in is the changes in bone mineral density after ACL reconstruction. What we've seen is that in the distal femur, there are pretty large deficits. I've had two abstracts so far and another one hopefully coming out soon, and then working on a paper that is really kind of quantifying those changes in our athletes out to 2 years. And it's pretty substantial, about an 8% deficit in bone mineral density in their distal femur. And it's been shown in a few studies, but nothing recently. The most recent was in 2010. There was a systematic review on it, but pretty much showed that there's not a good consensus on how much and where and locations. But we think it's primarily the distal femur that we're seeing it, and it's pretty interesting that we can pick it up on our full body DEXA scans that we're using in clinic. So that's one of our projects. But we can also look at lean mass and fat mass percentage and all of that stuff as well. All right, I guess I
Very
can
cool.
move along here. Let me see if I can advance this. All right, you can see that now, right?
Yeah, it looks good.
All right, so I'll play this is just a video of one of my fellow lab members, more of just to visualize what it looks like running in our lab, kind of the 2D video that we are collecting along with our 3D motion capture. So in this situation, you can see all the markers on him. And then the treadmill is a dual belt treadmill with force plates underneath it. So we capture our ground reaction forces. And then from that, we can use the motion capture combined with the forces to look at moments and powers and everything about the joint and calculate all those. And that's a lot of what I kind of talked about in the blog. We look at like the knee extensor moment. That's the most commonly reported metric after ACL reconstruction. When you look at gait or running or a lot of times hopping, things like that. And with good reason, there's usually pretty large deficits in that. So that's really what, and it's what the quadriceps function is to create a knee extensor moment essentially. So that's why we tend to pinpoint on that. So if I advance forward, one of the first things we talk about is just the angles. So looking at knee flexion angle, and one of the largest deficits that we saw in our cohort and really kind of has been shown in other studies as well is that the peak knee flexion angle. So at that about mid stance usually is when they're at the lowest point. We're still seeing pretty large deficits out to a year in our group. And then, so this, if you look at the curve on the right here, let's see, do you see my clicker? I can put a pointer on here, I think, in just a second. There we go. Awesome. All right, so this is essentially their initial contact. And then as they're going into, and this is just a representative plot that I found, nothing in particular about this one, I guess is interesting, but essentially they get to usually around 50 or so degrees of knee flexion as a peak knee flexion, and then extend the knee for takeoff, and then have about 120 plus degrees of flexion during swing phase. And that's the typical gait cycle that you'll see during running. But what we really pinpoint on is looking at the difference that you see between limbs at that peak knee flexion angle. So that's one of the variables. I think that one most people should hopefully understand. It's just geometry essentially. But then the next one, this is the one, moments, is I think what typically people get hung up on a little bit. And I like to kind of simplify it down, as it's always comes back to where the ground reaction force is acting about that joint. So if you have a ground reaction force vector that is shooting in this direction, essentially this looks pretty much vertical because they're about mid stance, but there's probably some forward and backwards lean to that line ever so slightly. If you take that and take a perpendicular line to that point, what I have labeled as R here, that would be your moment arm. And so moment is essentially equal to the magnitude of that ground reaction force times that moment arm. And so the torque about the knee has to counter that, because if the way I like to think about it, I simplify it down where I think of like if you scrap down, say, this body to just bone, where it was only the bones, and there was a force acting on it in this way, what would it do? It would collapse yourself behind, your knee would bend, you would fall into flexion. So if you're falling into flexion, what do you need to counter that? You need a knee extensor moment. So that's what the M in this situation is the torque produced about the knee. That is an extensor moment. So if we look to the graph on the right, this is now the typical ground or knee moment curve that you'll see during running. So again, the far left is your initial contact. You'll see this moment will increase substantially, and close to mid stance or so, you'll have this peak extensor moment, and then it will transition as you go towards your push off, and then this is your takeoff and to your flight phase. So really what we're interested in is what's happening when the leg's on the ground, because that's when you can calculate the ground reaction forces. And when you're in the air, there's no ground reaction forces, so the moments are not as easy to calculate with ground reaction or with inverse dynamics. So anyways, that's essentially another variable that's very commonly reported is you pull the peak moment off of it and compare that side to side. You can either do an LSI or just look at the magnitude of that, and that's essentially what we have done as well. There are plenty of other ways to explore this. Like you can look at different parts of this curve. You can look at the rate of that moment. So how quickly do they get up to that extensor moment? You can look at the impulse, which would be like the area under that curve. And then there's also analysis that you can do for more of a time series analysis. I think Mackenzie White talked about that a little bit, of doing some functional data analysis or something along those lines, where you can actually compare two curves to each other and find the places that are significant. So I've been exploring a little bit of that with what's called statistical parametric mapping. It's a pretty similar type of technique to do that. But anyways, these were what I talked about in the blog as the knee flexion angle and the knee extensor moment. I guess, Matt, do you have any questions on that before I jump to just the ground reaction forces? Or is that?
No, I think that's very nice and clear. I was wondering if you ever get like an engineering student or a physics student as a patient, and you sort of break out the free body diagrams for them. I find I have engineering patients, and they're engineers, but they love this stuff. They eat it.
Yeah, really. I've actually had
most people.
Yeah. Yep, most people, but it's fun when you get somebody who understands what you're talking about. I had a few BME students as patients at one point, and it was awesome to be able to like talk about these things, and they really understood what I was talking about, which is fun.
Yeah.
All right, then moving on, I guess for the other part I looked at was just the ground reaction forces. So take out the knee angles and look at just the force that essentially foot on the ground is creating, or the ground on the foot, either way, however you picture that. And so in this scenario, you have I'm looking at strictly the vertical component of that force. So straight up, how is that force acting on the body? And this, I think, is what most people should hopefully be familiar with. It's probably the most frequently reported biomechanics variable when we look at running mechanics, is looking at the vertical ground reaction force curve. So this one's kind of unique that I pulled. This individual has a little bit of a different foot strike pattern from side to side. Typically, you get kind of that oven mitt look for somebody who's more of a heel striker. So you get that first initial impact peak. And then where it's kind of just a single hump over that, or there's not as much of that first thumb component of a mitten, that's usually more towards a forefoot or midfoot strike. So kind of interesting, actually. That's why I picked this one, because it showed both and you could compare both. But essentially what I was talking about in this blog was we looked at vertical ground reaction force impulse. So that's essentially just taking the area under the curve of this plot. So essentially you're taking that vertical ground reaction force, and then you're integrating or doing a function to take all the area that's underneath that curve and comparing those two. So it's kind of a measure of how much time that they're on the ground compared with, as combining the magnitude and the time that they're on the ground. So that's how impulse plays into this. And then the opposite, you also have forces acting in other directions. So this would be your braking force. You need to have braking force, otherwise you constantly accelerate forward and would fall over eventually. So the braking force is what balances you as you're running. And so think of that as the ground pushing straight back at you at the bottom of your foot. And this, from a magnitude standpoint, is significantly lower than what we see in the vertical direction. But it's actually, I think it's a really interesting measure to look at in the ACL population, because it essentially, if you think of like a knee extensor machine, like if you're sitting at a knee extension machine, it almost is like acting like that, where you have to extend your knee to counter that, so that force coming back at you directly. But anyways, we very similar to the vertical component, you have this braking impulse curve, and I put this little line here. This essentially shows, oops, I think my pointer's a little bit off. There we go. It's floating around a little bit weird. Anyways, if you see that vertical red line, that's essentially where it transitions from a braking force to a propulsion force. So then the force is actually acting forward, and you're starting to push yourself forward. And that's typically about 50% of that stance phase or so. So again, we can, where that braking impulse is, we can take that area under the curve, integrate that, and that gives us a measure of braking impulse. So those are the two other ones that I think I talked about in the blog, and I think that's it for what I put together, I guess, to share to help explain those variables. So I'm happy to answer any other questions on that.
No, that's great. I don't have any specific questions about that.
Great.
It does seem like most of the action happens in the first 20% of the gait cycles. Does the rest of it matter?
The beginning, your initial, I wouldn't say just your 20%, but all the way kind of to mid stance, your weight acceptance phase. That's the important part of gait, I would say. But I'm not going to say that the propulsion phase doesn't matter. You do need to create some propulsion. And although the knee extensors are not the primarily responsible for propulsion, that's more of your soleus and gastroc complex. It's still important. So I wouldn't go as far as saying the rest doesn't matter. But yeah, definitely from this population, what I'm most interested in, most people are, is that weight acceptance from initial contact to about mid stance or so.
Okay. Do some people have spontaneous resolution of these asymmetries, or does everybody need gait retraining after an ACL reconstruction?
I would say it's very unlikely to see just spontaneous resolution. I've seen very few people that have full resolution, and most of the time the athletes that we do a detailed analysis on, where we're doing the 3D motion capture analysis while running, they may look great on everything else, and then we capture their movement, and you'll see pretty substantial deficits still at the knee. So I don't think it spontaneously resolves. I'm sure there are cases out there of people that do, but the vast majority are showing pretty large deficits beyond the time of return to sport. There's plenty of studies out there that have been, 2, 3, 4, even 5 years out, and they're still showing deficits in these metrics that I'm talking about. So I don't think gait retraining is necessary for everybody. I think some people may be able to, transition to running earlier, but it may be a viable option. And again, we're pretty early on in this line of research that it's hard to say what gait retraining is necessary at this point.
Now we know that from a publication from Matt Chan and Susan Sigward, that some of these asymmetries can be really well hidden. This particular study, they use a squat task, but people are real crafty at shifting off of their either away from their knee or off of their involved limb. Are we able to pick up these gait deficits, like the old-fashioned way with an iPhone?
Yeah. For the data that I kind of put together in this blog, talking about those 13 athletes that we looked at, we saw, at about 4 months out, we saw about 13-degree deficit in knee flexion angles within the involved limb. And then, still follow them out to a month, they're still at about a 9-degree deficit. If you look at the literature comparing about, what 2D metrics can, or using like a camera or a coach's eye or some sort of app like that, trying to assess the angles in that way, you'll find that the like minimal detectable change is usually a ballpark probably around 4 to 5 degrees. So this is well outside of that 4 to 5 degrees. So I think you should be able to pick up on people that have large deficits. You're not going to catch the small ones, obviously, anything that's a little bit less than that. But I think at this point, the important thing is really trying to capture those people that are pretty bad. And that's where you need to potentially intervene in some way.
Sorry, I got a 4-year-old growling in the background. So you mentioned your research subjects. Can you expand a little bit on the 13 subjects return to sports status and whether or not that related to their gait mechanics?
Mm-hmm. Yeah. So I can't necessarily say if it related to their mechanics, because the way that we collect our data is we're essentially you can almost think of it as we're like a service for the athletic department, that the athletes come to us, we test them, we provide the information on their tests, and then they go back to their athletic trainers and sports med staff and do their rehab there. So we're kind of helping out and saying these things, and we're not making the decision for them on return to sport. But I will say in this population, in this cohort, I think only 2 did not return to sport. And the reason for not returning was 1 left the team for unknown reasons. So we never had more follow-up from him or her. I can't remember who it was, and then the other one, they graduated. So that's the other problem you run into with college athletes, is eventually they graduate. So if you catch them at the end of that, we don't have more data on them. But the other ones all returned to sport, at least in the short term. And maybe I think 1 did re-injure during it, but the other ones, I think, were able to return. But I guess I don't have a strong answer of saying if that played a factor, because with 13 subjects, we can't really look into that quite yet.
Yeah, what's the long range goal of this particular study? I mean, how many athletes are you going to look at?
So it's just it's ongoing data collection. We essentially have a rehab protocol that we follow, where they come in at specific time points after injury. We try and capture them before injury. That's where we got this unique data set. But it's really, really hard to get pre-injury data, even on the ones that we've had 13 over, probably 5+ years of doing this. So it's hard to get the numbers for these, but it still provides a pretty unique data set to look at and give some new insight. But I mean, long-term goal is we just keep adding to it and keep getting a larger data set and being able to continually refine and look at more things. The more power that we have, the more we can look at from a statistic standpoint.
Okay, so you're so you had a bunch of athletes, but only 13 of them tore their ACLs. So how many?
Oh, I think I get your question.
Yeah. So you're just like screening people and say, okay, I hope you tear your ACL.
So most teams at UW-Madison, not all, but the vast majority of our teams undergo preseason testing, or as they come in as a freshman, they do baseline testing where we capture we get their motion capture data, we get their DEXA scans, we get their jump data, we get wide balance, we get a bunch of data on them right off the bat. Wow. When they come in and they're hopefully healthy. We do get a fair share of people that do come in with injury, and then they enter our injury protocol, but then we don't have that early time point. So that also happens a lot. But yeah, I mean, we screen probably, I think the number's over 200 a year gait tests that we're doing across the board. So we do a lot. I shouldn't say we, I should say one individual from our lab, Mikkel, does a lot.
How common is that? I went to a D1 school. I played football, and I didn't do any of that stuff.
Yeah, it's pretty unique. I'm not aware of other programs that do the full motion capture setup. So, yeah, I'm really not sure of others that are doing it in the way that we do it.
That's really cool stuff, though. Okay, I have one. I think I have one more biomechanics type question, and then I think I have more clinical type questions after that here. So this question asks, it's not clear from the graphics, but do ground reaction force values restore to pre-injury levels by the 12-month mark? And is this in line with other published research?
Yeah. Sorry if you weren't able to tell from the graphic. It should. So what we saw from let me just have it up here real quick so I can make sure I say the right numbers as I'm going through this. Here we go. So for the vertical ground reaction forces, or the vertical ground reaction force impulse, what we saw is there was a significant difference at our 4-month and our 6-month time point. But once they got out to the 8-month time point, we only saw about a 3% deficit in that metric, which was not significant. So essentially, that shows that they're recovering or restoring their vertical ground reaction force impulses by around 8 months in the surgical limb. On the other hand, for the non-surgical limb, we saw about a 4% increase in vertical ground reaction force impulse that was significant at the 8-month time point. But again, at 12 months, this was also recovered. So for vertical ground reaction force impulse, which I found this really interesting because there's a lot of studies that look at vertical ground reaction force in some way, either peak vertical ground reaction force or vertical ground reaction force impulse. This is the metric that seems to recover the earliest from what we saw, and actually restored to their baseline levels. So even though we're seeing that recover, we're still seeing pretty large deficits at the knee with those changes. Now, if you shift over the braking impulse, that was the other ground reaction force variable we looked at. In this one, within the surgical limb, recovered by 12 months to within about 5%, and that was not statistically significant. So I would argue that that's essentially recovered by 12 months. However, in the non-surgical limb, it actually was increased and stayed increased at a significant level. It was up about 14% still at 12 months on the surgical or non-surgical limb. So a little bit different than what we saw in the surgical limb, or I mean in the knee kinetics and knee kinematics. So like the moments and the angles. So very, very different there.
Why is that? Why do you think that is? Why did their non-surgical limb maintain a higher braking force?
It's a good question, and it's hard to kind of dive in. I guess my thought is we still see these compensations side to side, and that other limb is just trying to compensate to keep their pace up and keep their tempo where they need to go. And because they're not braking as much on their surgical limb, they have to kind of brake on the other limb a little bit more to keep that balance of propulsion to braking even. That's, I guess, my thought, but I think there needs to be a deeper dive to try and figure that out a little bit more. Yeah, good question though.
Okay, I have one more biomechanics question, and I'm sorry, this is going to be kind of a dumb question, but so vertical ground reaction force is how hard the earth is or the ground is pushing back up on you, right? So you push down, it pushes back. Okay, so that depends partly on your body weight.
Correct.
Right.
Yep.
So the body weight's not going to change from month 3 to month 8 when it gets restored. So what's changing to make it back to a normal baseline? Or maybe the body weight does change. It's not going to change it much, right? So what are the things that the person is doing differently to restore their vertical ground reaction force at the 8-month mark?
I think it comes down to what they're doing at the joint level. Are they moving through more range of motion to essentially absorb that forces, or increase their loading by putting more support through that leg? Those metrics that we actually looked at for the ground reaction force, they're normalized to body weight. So that actually, the change in body weight likely, it's essentially factored in by when you normalize. So,
the load has to be absorbed and then returned, right? Or stored and returned. So maybe the impulse is different, but like the total area under the curve should be the same, right? Or it's not as steep of a curve, but it's. Am I off base here? Maybe what they're doing is they're catching more air. They're coming down harder.
Yep, they can come down harder, and they could have less time on the ground too. That will also change the impulse as well. So if they change the time that they're on the ground, that's another way to quickly change your impulse.
Okay, and that's probably an indication of a fitter athlete, right? Someone who spends less time on the ground.
Less time on the ground, yep.
Okay, all right. Thank you for humoring me.
That's a good question.
All right. So, what are the variables do you guess or do you see in the data so far that are likely the best targets for identifying and addressing gait problems after ACLR?
I think there's a few options to go, and I don't know if there's necessarily a best. There's pros and cons of each. So, if you start with the knee angles, the peak knee flexion angle, I think that's a very logical place to start. You can detect that with 2D cameras potentially for those that we kind of talked about already that have large deficits. You're going to see that on a camera. You'll see it with the naked eye if it's large enough. The downside to that is you don't. I mean, I guess it's a positive is you don't need the ground reaction forces to look at that. So if you could potentially modify that in a laboratory setting, show that modifying that angle really changes the moments and the other aspects that we're concerned with at the knee, then that would be a great option to go with.
Like that Evans Pickett article where they was a walking study, right? They were
exactly
giving real-time feedback for ground reaction force.
Yeah, so that was on ground reaction forces though, versus the knee angles, a little different that you would need to potentially provide that feedback. But I think with the advances in IMUs, there's potential for IMUs providing joint angles as
What's
well
an IMU?
As inertial measurement unit. So essentially accelerometer and magnetometer and a few other things built in to give you, and you have to do essentially some complex mathematics to get it to work. But there are commercial products that do give you joint angles from those already developed. So that is a potential, I think, viable option in the future. And then markerless motion capture. That's another, I think, really interesting route that could be explored and be very clinically useful. Because if you don't need to marker somebody up, that's what takes the most time of doing data collections for these. But I guess moving on to other ones, I think the braking impulse. So if you do have access to ground reaction forces, braking impulse may be a really interesting one to tackle, because that's one that we saw changes on both limbs. So if you essentially set a target if you could give real-time feedback and set a target that's kind of the midpoint between the left and right and balance those out, you may see mechanics change. But a lot of these need to be explored. And then I think the best option would be if you could look at knee extensor moments, because that's, I think, what we're most interested in is, are they loading through the knee properly and similarly side to side? And so if you could give real-time feedback on peak knee extensor moments, which I believe in the blog, I had a study I cited that essentially has done that, but in a single case, or in a single study, not a single case, but it's challenging to do.
Yeah, I bet, especially in the clinic. Okay. All right. So I have, now clinical questions here. So regarding objective criteria to return to running after ACLR, are you using any specific ones besides what we already know from Rombod et al. From 2018? Maybe if you know off the top of your head, can tell us about what those objective criteria are.
I can't remember off the top of my head. And I would say the main takeaway from that is that there are not well supported return to running criteria at this point. that's the major thing that I see. But
the one that I remember off the top of my head is 70% limb symmetry index. That's
there's various studies that use either like 65, 70, 75, I think is what they've had reported. But I think I use that. I would say I shoot for at least 70% limb symmetry before advancing to running. But I try and take more than just like the strength as the only metric I look at. Like, yes, I want them to have the strength. And if they don't, I'm usually just telling them, hey, we got to keep working on strength. That's got to come along before we can jump into these things. But I also think there's other aspects. So their ability to accept weight onto a single limb. Running is a single limb task, essentially. It's alternating from one limb to the other. So if we want them to be able to drop into mid stance to about 45, 50 degrees of flexion and be able to support their body weight, I personally like to see them do that with like a single leg, like a bound where they jump from one leg to the other and try and sink. And that's something I'll train a lot ahead of time is really working on, okay, can you do this task and land in a knee flex position and be able to support yourself. So that's something I start out with, I think, and I want to see somebody be able to do before saying, I'm okay with you doing some running.
I think that's great. Where do you see clinicians going wrong when they're getting people back to running? And do you think that residencies or programs like that are helping those clinicians out and be better?
Yeah, I think there's probably two major aspects that I think clinicians maybe go wrong with this, and I probably have many times as well working with patients, is because sometimes it's hard to objectively measure these things. But if you're looking at, like, say, strength, I think that's a factor to consider. But I think the first thing is people return too early. I was actually pretty surprised when that Rambaud paper that essentially showed 12 weeks, 3 months, 3 to 4 months, that's the most common start time. And to me, I feel like that may be too early. There's too large a deficits in quad performance at that time. And I think there are other things that may be more important to be working on, especially if the athlete's goal is to get back to sport. Like, yes, running is a very important part of sport, but I think there's plenty of other aspects that you can work on that may help their running. That isn't necessarily just saying, hey, go out and run. And then that leads me to the second thing, I think from a dosage standpoint, returning to run, it really needs to be pretty specific of avoiding, okay, great, you're at 12 weeks, you have decent strength, you can start running now for your aerobic exercise, and just giving them maybe a generic return to run. I think it needs to be more specific than that. I don't have a great, I guess, example, but I tend to try and hold off on running and really focus on like more sport activities and maybe short runs, short spurts of accelerations where they're actually working at faster speeds versus just, all right, go out for a nice easy jog, don't go too hard or anything like that. If they can support themselves on one limb, usually I try and get them moving a little bit quicker, but in shorter spurts.
What do you think about residencies? I mean, I think you could probably speak most confidently to your own residency, but I'm just curious if you got your finger on the pulse of residencies in general.
In general, I probably can't speak to it because they vary so much from residency to residency. So I know it could be a completely different experience at another place. But I can speak to, I guess, my time at UW Health and as part of the sports rehab program there for my residency. We are, I would say, pretty spoiled where I work now. We have an instrumented treadmill in our clinic that we get to use on a regular basis. We have force plates in the ground that are all set up to assess ground reaction forces during jumping and hopping and all these things. So I use that on a daily basis. When I most days, I guess, I am usually using either the treadmill or the force plates, and it's a great way to give objective data, show the patient what we're looking for, what we're seeing, and how we're going to try and address it. And so I think that's really valuable. And we also are surrounded by some awesome clinicians. So UW Health has a unique setup with a runners clinic that's strictly for runners. And there's a bunch of clinicians that are really experts at treating runners. And so I got to spend a decent amount of time with them and learning from them. And so, yeah, I think it helps. But again, from the literature standpoint, there's not as much when we look at ACL and running yet. But hopefully we can help make a change in that.
Yeah. where does gosh, where does an Ultra G fit into this? Is an Ultra G a useful tool for this this population?
Personally, I don't think that it necessarily fits. The major issue we see is that the individual underloads their knee. So putting them in Ultra G, one, we know that it changes mechanics somewhat. Once you offload their body weight, some of their mechanics are going to change. And it's likely going to reduce the amount of knee flexion they're going into. So I think it could actually be counterintuitive if you're offload.
Yeah.
I understand the fact of like if they are not comfortable loading that joint yet and you try and offload it, but that just probably means they're not ready for running yet. I would rather wait and have them work on ground running. Yeah, I never use it. I can see it for stress fractures, things like that. We do have one, but I never use it.
Okay.
From that standpoint, yeah.
Yeah, that makes sense. And in your blog, you talked about one of the, maybe one of the clinical tools you use is decreasing cadence, right? For that exact reason, is to increase load on the knee, right? Did I read you right?
Yeah, and that's more of like an exploratory thing that I think needs to be explored because they're in healthy subjects. There's data to show that decreasing cadence increases your knee extensor moment, increases the peak knee flexion angles that you go into. So if that carries over to the ACL population, it may be worth trying and seeing how that works. I think there may be even better ways to do that, where if maybe you restrict their cadence and actually have them hit a target cadence that they normally are at, but make them bound. So the things that I was talking about external cues of being bouncy or bounding with each step, if you increase kind of that vertical displacement, that usually is going to have them require to bend their knee more to absorb that. But a lot of times when you do that, they'll slow their cadence way down and then it looks funky. And so if you can keep their cadence more consistent, but that's again, something I want to play around with a little bit more. I don't have any data yet to support that.
What we need to identify these key variables here, and we need to find a way to measure it quickly and efficiently in the clinic. And then we need to gamify it so that you put someone with a screen in front of a treadmill and you say, okay, well, you have to, whatever. You're racing against Usain Bolt on the track here, and in order to beat him, you have to meet these criteria. We're not going to tell you what those criteria are. Don't worry about that. Just focus on the task at hand.
Yeah.
So partners on that, Shark Tank.
I think that you're actually on a really good path of where I think things may be going is if we can get biofeedback on, specific metrics that we want, say peak knee extensor moment or knee flexion angle, and you can put it up on a screen in front of a treadmill and have them run, even if you don't tell them like, hey, this is going to change by, if you bend your knee more, this is going to change. You can simply say, there's 2 bars, make them even, or set a target and say, hit this target. And have them go and have them figure it out on their own. Not tell them. You might be able to give them hints here or there, like things that you've heard, like cues that have worked. But even so, I'd probably just let them explore it and figure it out, and eventually, hopefully, find what we're looking for and stay there. And then you try and do a faded feedback of some way and see if it holds.
Yeah, that's perfect. How much one-on-one time are you getting with your patients?
In clinic, we have 60-minute evals and then 30-minute follow-ups.
Okay.
And then for ACL populations, we do what we call a progressive testing session, which is an hour-long session with them.
Yeah. Okay. That's nice to have that.
Yeah.
Okay. Question on Instagram. If someone has passed their strength test, but they're still limping when they're running, are you going to let them run? What are you going to do?
If you see like a pretty substantial limp and you can visually catch it, I'm usually saying, hey, let's hold on running and work on the things that can help prep you to run. Even if they have strength isn't the only component you got to consider. There could be a bunch of different factors that play into why they are limping. Are they having pain with loading? Are they fearful of bending the knee? There's a lot of things I think that could play a role in that.
Are you going to take that person before you pull them off the treadmill? Are you going to try to modify their cadence or something and see if you can clean up their gait? Or are you just going to say, let's work on some stuff and try this again in a week or two?
If they're not having pain and it's not like they're, that's the limiting factor, then yeah, I may try modifying it a little bit. Even with some pain, I think you can try modifying certain things if needed. But most likely, I would say, hey, let's just work on more weight acceptance drills, getting you used to loading that limb, if that's the case, and see if we can work on it that way. Yeah, I probably wouldn't jump to any sort of gait retraining right off the bat. I kind of want them to explore the movement after they have their strength back and are feeling good. But if it continues to be a problem, then I think you got to step in and do something.
Can you, let's see here. Is there any specific work you like to do for training knee flexion on the injured side? Plyometrics, eccentrics, external focus cues. That's a good question.
That's a really good question. And yeah. I mean, I think I've kind of mentioned some of them. I'm a huge fan of doing like bounding drills where taking off of, one limb and landing on the other forward. So you have to have that deceleration component, but making them do it to where they're landing in a very like a flexed position. So more of a bound and hold I'll start with, and then I'll do like a repeat bounds to get more limb to limb quicker. I think you can also go through a progression of, that can be regressed to where you're simply doing a step and hold and do a single leg squat. I use that a lot fairly early on just to try and prep that of take a step and then drop into a single leg squat quickly. So they're working on that quick deceleration component into that squat. You can also use things like box landing. So step off a box, land onto one limb. Can you do that and land in good positioning with a flexed knee?
Are you using your force plates or I can't remember. Did you say motion capture in your clinic as well?
We have the capability of doing it. We don't use it clinically. No, because it takes too much time to mark people up and everything. But we use just the force plates clinically.
Are you using those with your box jumps and giving people, quantitative feedback?
Not with the box jumps per se. I will
drop jumps.
Use it. We'll use it for counter movement jumps. So we'll 2 feet on, jump, land on it. We'll use it for a single leg vertical hop. So taking off of one, landing on that same limb. We also have another set of force plates that give us direct biofeedback on limb loading. Just a simple vertical ground reaction force. And so they stand on one of 2 plates, and I use that with post-op, early days with like starting to do mini squats and things like that, and watching, are they loading evenly with those?
Now most clinics have those.
Yep.
Most clinics will have those. They're called neurocoms, and they don't usually get used very much. They just collect dust in the corner of the clinic, in my experience.
Yeah, I like the way we have it set up where it's always kind of on. So all you have to do is step on and go, and it's really pretty efficient. So I like using it to like help people that individuals seem to struggle realizing when they're not, when they're offloading. So I'll use that to get them to, realize, oh, this is even from a ground reaction force standpoint. Now try and replicate that and remember to do like how that felt and practice it a few times. And then I'll have them turn around so they're not looking at the screen and do it the opposite way and practice it that way a few times and then look back and see if they're doing a good job with it. But yeah, I'm a fan of using those. I'll do jumps on that as well if I want to look at that real-time feedback side to side.
Nice. All right. What about like knee confidence or outcome measures, like the COOS? What can that tell us about someone's ability or interest in loading their knee during running? And are you aware of any research that specifically relates it to running?
Specifically relating it to running, at this point, I don't think so. We've begun to explore it a little bit, but I can't really speak to that yet. But there's a slight relationship, I think, to, we use the IKDC, so that's what we were using. But I think if you're looking more sphere specific, if you're looking at like a Tampa kinesiophobia scale or the ACL RSI for more of a confidence component, I don't think there's just data out there yet for that, but I think it definitely could play a role in their competence and ability to accept weight on that limb. Yeah.
Yeah. Are you guys collecting that data on your current ongoing data collection efforts?
Currently, we do the IKDC. That's the main one we do.
Gotcha.
Yeah, that's what we've been doing for a while, so we're stuck with that one.
Okay. Cool. Well, it looks like I think we covered pretty much everything. Is there anything you want to share? Anything you want to get out there? You want clinicians to we want clinicians to be better. Is there anything that we didn't cover that you're like, yeah, you should know this?
I think my big takeaway is just don't fall into the trap of simply just saying, oh, you hit the 3-month or 4-month time point and you seem to be doing okay, so you can start running. Like try and think of it a little bit more of what the end goal is. And if the end goal is that person is a runner and their goal is to get back to running, then I understand potentially working more on running. But if their goal is, hey, I want to get back to basketball, or I want to get back to football, or I want to get back to soccer, yes, running is a very important component, but it's not just inline running. And I don't think in this population, with the amount of deficits that we see, it's a good idea to start them on a return to run program right away and just say, hey, go out for your 20 to 30 minute jog whenever you want now that you're this far out, because I think that helps, one, ingrain that pattern of this is how you're going to run with these pretty substantial deficits, and then two, what is that going to do to the long-term joint? I think the joint health, and that's what I talked about in the blog a little bit, is if they're running with these really altered mechanics, they can be loading the cartilage in a way that it's not used to, and that potentially could be detrimental in the long term too. So I think just being a little bit slower to jump the gun and let them run, and make sure that you really feel that they're ready from a strength and ability to accept weight onto that limb, and watch them run. That's the other thing. Watch them run. Take a video in clinic. Make sure that you don't see any really major deficits, because if you see it with your eyes, it's probably pretty substantial.
Yeah, and I'll just I think that's great, and I think I've been hosting these blogs and these courses now, and I think it's probably to me it's easy to kind of get overwhelmed with how much information's out there and feeling like you need to check all these boxes and things. But I think for like a clinician who just who wants to like do better at this, I think just being deliberate goes a long ways. And just being like, hey, there are these certain things that we know are really essential, like strength and full range motion and quiet knee, and being cognizant that there are these really really well hidden movement deviations, and then being just real deliberate about return to running, I think goes a long ways. And then you can get into the minutia as you go along. But I think just sort of having just being careful and caring about helping your patients get better goes really a long way.
Absolutely.
So.
Yep.
Well, Keith, thanks so much for your blog. Thank you for sitting down with me and answering these questions. This was super fun. You got to wrap us up. There's no more blogs on the horizon as of right now. No more Q&A. So I was really glad we got to end it this way. This was great.
Yeah, thanks, Matt. This was a lot of fun. And thank you for everything that you've done with the ACL Study Day. It's an awesome resource for clinicians and researchers.
Oh.
Like I love it.
Yeah, thank you. Yeah, thanks for participating in that. So
yeah.
All right. Well, you have yourself a great night.
Yeah, you too. Bye.